Hi, I'm Dr. Rob Myers and this is Cardio Talks. I'm a cardiologist at Sunnybrook Hospital. The goal of these videos is to explain common cardiac conditions in a completely understandable, digestible manner. This discussion is going to be about stroke prevention and atrial fibrillation. So as I've talked about before, atrial fibrillation is a super common rhythm problem, really hard to manage. The approach is really twofold or two prongs. One is the rate rhythm approach. So how do we deal with the actual rhythm problem you have? And the second is how do you deal with the risk of strokes? The problem with atrial fibrillation is even if you don't feel it, your stroke risk is up. And oddly enough, it seems sort of counterintuitive, even if it comes and goes, you still have a stroke risk similar to somebody that's always in it. So why do you get strokes with this condition? Well, the upper chambers of the heart, which is where the rhythm originates, instead of these upper chambers sending out blood in an orderly manner to the lower chambers, like this, they fibrillate. They do this. And when they do that, you get stasis or lack of movement of the blood in the way that it should. And when blood doesn't move properly, it clots. You end up with a thrombus. A thrombus is just a medical term for a blood clot. We doctors like to use words that people don't understand. I don't. I like to use words people do understand. So it can be the size of a period at the end of a sentence. These can be very small. The issue with formation of blood clots is it depends on the patient, depends on you. There are a series of point systems. It's a scoring system with points. And the higher the points, the greater your yearly risk of stroke. It's called the CHADS-VASC score, CHADS-VASC. CHADS-VASC 2 is a new one. So it's exactly what it sounds like. It's like points. Each letter refers to some point. So who gets points? If you're over 65, you have a higher risk of stroke than if you're under 65. Obviously, it's a bit of an arbitrary cutoff, but you have to have some. So that's 1 point. If you're over 75, your risk is considerably higher. You get 2 points. If you're a woman, you get 1 point. And then other conditions give you a point. Blood vessel disease, a weak heart muscle, diabetes, high blood pressure, previous stroke really raises your risk. So you go through this, which should take somebody about 60 seconds. Like it doesn't take any time. And it spits out a number. And then we look at large studies and it gives us a bit of a dull sword where I tell you what? I tell you what your 1 year risk of a stroke is. That's what the point system tells me. It's cumulative, so it doesn't stop at 1 year. Every year, that's your risk. And that's an important sort of template to think of is, I'm going to sit there and chat with you about your risk, and I'm going to tell you, what is your 1 year risk? Because numbers in medicine are everything. So the more points, the higher the risk. Now, if you've got 0 points, you still have a risk of a stroke that's higher than your twin who doesn't have atrial fibrillation, but it's not high enough to justify any treatment. And what is the treatment? Just what you don't want. It's an oral anti-coagulant, OAC, also known as a blood thinner. So if the blood is clotting and forming these blood clots, then we want to inhibit the body's ability to do that, so we use a blood thinner. Now, some of you may still be on Coumadin. Coumadin is a 1950s drug. I think Harry Truman is the first person that went on Coumadin. And it's a pain in the butt because, as you know, if you're on it, you got to get your blood measured every week, every 2 weeks sometimes, to see whether your blood thinning is at the appropriate level. Also, diet impacts it. Alcohol does. If you decide to have a kale salad once a week, it's going to mess it up. It's because greens have a lot of vitamin K. And Coumadin acts by inhibiting the activity of vitamin K. And vitamin K is necessary to form some of the elements of a blood clot. So if you overwhelm your system with kale or salads, you're going to have a lot of vitamin K and your blood thinning will drop. Anyways, enough about Coumadin. Hopefully you're not on it. The other drugs, though, are more expensive. And these are called novel oral anticoagulants, but they've been around over a decade. I don't know how novel they are anymore. There's a bunch of them. They're basically interchangeable. I'm not going to split hairs on which one is better than the other. And they act in a different mechanism. They're just as effective, actually they're more effective. They're better than Coumadin. Their complication rates can be even a little less. And you don't need your blood tested every week or two. You just need your blood tested just to make sure you're not anemic and it's not causing silent bleeding. So these are much, much better drugs. What are the side effects of these blood thinners? Bleeding to death. Now, I put it that way, of course, you're not going on it. But as I've said before, it's like, what's the side effect of a going on a plane. So it's not what can happen to you, it's the frequency. I can't emphasize that more. You won't do anything if we tell you about side effects. You'll sit at home. There'll be a side effect from that. So, people that exercise, when I'm watching you exercise for that half hour, an hour, you have statistically twice the chance of dying than I do. It's like, oh my God, I better never exercise. Well, over the course of a year, if you're exercising and I'm watching you, my risk of dying is over 20 times higher. Everything has a risk. I'm just being blunt about it. So the side effect and problem with a blood thinner isn't getting some bruising on your hand, suck that up. Can't do much about that. Everybody gets bruising, but it's having a serious bleed inside your brain or gastrointestinal that is potentially life-threatening. I had a lady who was climbing Mount Fuji. She fell and she bumped her knee. Her knee was like 3 times the size because she was on a blood thinner. If she hadn't been on the blood thinner, it would have just been a scrape. If you have an incidental hitting of your head on something, what otherwise would have been nothing could turn into something life-threatening. So you can't go on a medication unless you know that there's 2 sides to the equation. So the bad thing is serious bleeding, plus you can still have a stroke on these blood thinners. So it's numbers. It's a numbers game. If the chance of bleeding usually is 1% or less per year, and not all of them are life-threatening, and the chance of a stroke if you're taking the drug is less than 1%, then there you go. If the chance of a stroke not being on the blood thinner is 5% a year, you should be on the blood thinner. Now, I like to go through the exact numbers because I think people need to make up their own decisions about this. I'll follow the guidelines. I'll tell you that you have a 3% risk of a stroke, for example. Let's say your yearly risk of stroke is 3%. Well, half of those strokes are minor, incidental, and won't really bug you very much at all. So that needs to be integrated into your decision. Now, if you're comparing that with a 1% chance of a complication or a stroke on the drug, the guideline will say, I am obligated from a medical legal perspective to recommend the medication. But if I'm giving you all the information, make up your own mind. Because frankly, I'm not sure if I would go on it. It depends what your level of gambling is, I think. So that's the whole issue. You really need a fulsome discussion about a number. It's the numbers that matter, not just giving you complications. So if I don't tell you anything other than I'm going to give you this drug so you don't get a stroke, you're going to be freaked out, you're going to be scared, you're going to take the drug. So if the risk is 2 or 3 or 4%, you might be in a position where you're making up your own mind. You might be so scared of a stroke that you're going on it, and probably you should. Say your stroke risk is 7%. Well, you should be on the drug to reduce that risk. If you have a 7% yearly risk of a stroke, that's really high. So nobody wants drugs. I get it, but I'm not an expert on what you want. I'm an expert on what you need. So you go through your CHADS vascular score with your doctor and you get advice about whether or not you should be on these blood thinners. People want to take aspirin. It's not generally helpful. It's definitely inferior to an anticoagulant in stroke prevention by a lot. And the bleeding risk is pretty similar. So we don't tend to use it. Some people may go on it if they're young and their risk is low and they're not worried about bleeding, but they want to reduce their risk a little more. But aspirin is no replacement for an anticoagulant. And again, the overall difficulty with anticoagulants is nobody wants to be on them. But what you want and what you need are often very different things. So that's a summary of anticoagulation and stroke prevention and atrial fibrillation, and I hope that helps.